السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. أعزائي الطلبة, this lecture about the external ear disorders. Earwax. Earwax is a normal physiological substance that protects the ear canal. Earwax is a build-up of a cerumen, sebum, dead cells, sweat, hair, and foreign material like dust. The quantity produced varies greatly between individuals. Earwax may be either wet or dry. Wet wax is either soft, more common in children, or hard, more common in the elderly. This is the picture of apopilosebaceous unit, the sweat glands and the sebaceous glands. This is a soft wax, and this is a hard wax. Cerumen or wax has antibacterial and antifungal properties. The antimicrobial properties are due to the presence of saturated fatty acid, lysozyme, slight acidity of cerumen, the pH typically around 6.1 in normal individuals. Symptoms. Usually wax is asymptomatic, but it may be associated with diminished hearing, often of sudden onset after a cleaning of the ears, or discomfort. Seldom complain of pain unless the wax is pressing on the drum, and sometimes tinnitus. Earwax only needs to be removed if it causes symptoms or if a proper view of the eardrum is needed. Primary care treatment for the wax. In more severe cases, use of a cerumenolytic ear drops or wax dissolving agent for 4 to 5 days prior to syringing is advisable. Removal with wax hook is also an option. Ear syringing has been shown to improve hearing in those with impacted wax. The lowest pressure possible should be used. Ear syringing is contraindicated if the eardrum is known or suspected to be perforated, and if there is a history of mastoid surgery or tympanoplasty. Tympanoplasty means myringoplasty plus ossiculoplasty. Chronic middle ear disease like chronic suppurative otitis media is contraindicated for ear syringing. Recurrent otitis externa and tinnitus. This is the picture of how to do ear syringing using sterile water at body temperature 37 degrees centigrade without using of excessive pressure. Inflammation of the ear canal, otitis externa, may be divided on etiological basis into infective group like bacterial infection, localized otitis externa, furunculosis or boil, or diffuse otitis externa, and malignant otitis externa of diabetic and immunocompromised patients. Fungal infection, otomycosis, ear mycosis, fungal infection of the ear. Viral infection, herpes zoster oticus, and otitis externa hemorrhagic. We have diffuse otitis externa and localized otitis externa or boil or furunculosis. Diffuse otitis externa called swimmer's ear. Why? Because it is most commonly occurs in swimmers. The pre-inflammatory stage, the first stage, starts with symptoms of pruritus and sense of fullness, and the signs of mild edema. Mild to moderate stage, when there is a progressive infection, the symptoms are pain, increased pruritus, and the signs are erythema, increased edema, canal debris, and discharge. Severe stage of diffuse otitis externa, there is a severe pain, worse with ear movement, and the signs are lumen obliteration, obstruction of the ear canal, purulent otorrhea, involvement of periauricular soft tissue. Treatment of diffuse otitis externa. The most common pathogens are Pseudomonas aeruginosa and Staph aureus. The four principles of management of otitis externa, diffuse type, are frequent canal cleaning, topical antibiotic with steroid, pain control, analgesia, and instruction for prevention by avoidance of water getting into the ear. While localized otitis externa or furunculosis, it is a localized, acute localized infection involving the outer cartilaginous portion by obstruction of the apopilosebaceous unit, and the most common pathogen is Staph aureus. Symptoms of furunculosis are pain and diminished hearing level, and the signs are edema, erythema, tenderness, and occasional fluctuations. Treatment of furunculosis by local heat application, analgesics, oral anti-staphylococcal antibiotics, and sometimes intravenous antibiotics for soft tissue extension, incision and drainage reserved for localized abscess. Necrotizing otitis externa or malignant otitis externa or invasive otitis externa. This is non-neoplastic. It is a type of osteomyelitis of the external auditory canal involving the base of the skull. It is usually occur in uncontrolled diabetic or any immunocompromised patient. The patient presented with severe pain, severe otalgia, with the presence of granulation tissue in the floor of the external auditory canal. Diagnosis from the history: immunocompromised patient, especially diabetic, presented with severe otalgia. We need to do a CT scan of the skull base, and the treatment by admission of the patient, diabetes mellitus control, and systemic antibiotic using oral or intravenous antibiotic, and the antibiotic of choice here is ciprofloxacin 750 mg twice daily for 6 to 12 weeks, with frequent oral toilet, surgery by removal of the granulation tissue and the necrotic bone, and using of topical anti-pseudomonal antibiotic, but there is a high mortality rate. Inflammation and granulation tissue with the presence of blood-stained discharge, purulent secretion, occluded of the canal and obscured tympanic membrane, and cranial nerve involvement, especially the facial nerve most commonly affected, and sometimes involvement of the glossopharyngeal, vagus, and the accessory nerves. Otomycosis, fungal infection of the external auditory canal. The most common organism either Aspergillus niger and Candida albicans, aspergillosis and candidiasis. The symptoms of otomycosis are pruritus deep within the ear, dull pain, and conductive hearing loss. Signs of otomycosis are canal erythema, mild edema, white-gray wet newspaper. Wet newspaper يعني مثل ورقة الجريدة المبللة, and this is a sign of candidiasis or black fungal debris of aspergillosis. This picture of candidiasis, and this picture of candidiasis. Here aspergillosis plus candidiasis or moniliasis, and here mixed candidiasis plus aspergillosis. Also this picture mixed infection, candidiasis plus aspergillosis. Treatment of otomycosis by thorough cleaning and drying of the canal, topical antifungal mycostatin for candidiasis, or clotrimazole for aspergillosis for 1 month. and avoidance of water getting into the ear. Herpes zoster oticus, or Ramsay hand syndrome, is a herpes zoster infection of the geniculate ganglia of the facial nerve. We have 3 stages. Number 1, herpes auricularis, only rash involving the auricle. Number 2, herpes auricularis with facial palsy. Number 3, herpes auricularis with facial palsy and paralysis of the vestibulocochlear nerve. The symptoms are otalgia, malaise, headache, possible dizziness, and the signs are vesicular eruption of distal canal and the concha, occasional paralysis of the facial, and paralysis of the vestibulocochlear nerve. The treatment, analgesia, steroid for the facial paralysis, and acyclovir. This is the herpes auricularis, herpetic lesion of the auricle and the concha of the auricle. Here, herpetic lesion plus facial paralysis. Trauma. We have the hematoma of the auricle, auricular hematoma. The etiology, a blunt trauma, result in accumulation of blood between the perichondrium and the cartilage. The treatment by drainage under sterile condition, under aseptic condition, and using mastoid pressure dressing to prevent recurrence of hematoma. Antibiotic cover to prevent perichondritis. Complication of auricular hematoma is organization and calcification of the clot with necrosis of the underlying cartilage, leads to cauliflower ear. This is the auricular hematoma, and this is a cauliflower ear, which is a complication of recurrent auricular hematoma, which occurs in boxers and wrestlers. Auricular hematoma can be complicated, recurrent auricular hematoma can be complicated by cauliflower ear, الاذن القرنابطية. Laceration of the auricle, we have simple laceration, complicated laceration, and avulsion of the auricle. The simple one, treated by thorough cleaning of the wound with antiseptic solution like betadine, conservative debridement of necrotic skin edge and cartilage that cannot be covered with perichondrium, closure of perichondrium to prevent notching, cosmetic closure of the skin, and using of prophylactic antibiotic to prevent perichondritis. This is a simple wound of the auricle. The complicated one, treated by simple same above measures, and the contaminated or extensive wound may require staging with use of skin grafts or reconstructive flaps. While complete avulsion of the auricle, the amputated part should be cleaned and placed in ice physiological saline like normal saline until reconstruction. Anticoagulant and prophylactic antibiotic may be improve success. Laceration of the external canal, injury of the canal predisposed to stenosis. So the canal should be carefully examined, cleaned, and debrided under microscope. Skin of meatus should be reapproximated, and denuded areas covered with split thickness skin graft, supported in place with antibiotic impregnated gauze and packing. Burns treatment similar to general burn management, except prophylactic antibiotics are indicated to prevent suppurative perichondritis and stenting of a burned meatus necessary to prevent stenosis. Foreign bodies of the external auditory canal, either insects, and they are immobilized with topical 2% lidocaine, but lidocaine or xylocaine should be avoided when there is a perforation of tympanic membrane. Why? because it is ototoxic, can cause injury to the inner ear. Or we can use ether and remove the insect with gentle irrigation or oral crocodile forceps. If the foreign bodies are in other materials, all shapes and sizes in all age groups, and the key to successful removal is use of a proper instrument according to the type and the size of the foreign body, with using of microscope, alligator forceps, right angle hook, with using of section and local anesthesia. Young children often require general anesthesia to remove impacted objects without further injury to the canal or to the tympanic membrane. Topical otic antibiotics if localized reaction to foreign body. We have different types of foreign body in the canal. These insects can be removed by ear syringing, by using of crocodile forceps, or even by section. There is a bead in the external auditory canal with the presence of the perforation of the tympanic membrane, so ear syringing is contraindicated, and using of xylocaine is contraindicated, and this foreign body can be removed under GA. Thank you very much.